Yep, I think we're going live now. So welcome everyone to the October meeting of Health in Hackney. I've had apologies from Councillor Lynch. In terms of the usual matters of housekeeping, this is obviously a hybrid meeting with a number of councillors in the chamber, a number of our guests joining online. Those that are speaking online, please keep your camera on when it's your item, and but please keep your microphone off. Not your item. Please don't start conversations in the chat. Please raise your hand to get attention. We are being live streamed and recorded. Members of the press may well be watching. And I think those are the main items. Declarations of interest, please. Councillors, I haven't. Councillor Turbetalov.
Thank you, Chair. I'm a governor for Homentor Trust Hospital.
Thank you. We've got 4 substantive items on the agenda today. The first of these is in relation to the 10-year plan. And as we know, that came out earlier on this year. On the 13th of June, the outgoing chief exec, Zena Ettridge, communicated about the blueprint from that plan in terms of a 50% cut in staffing and about how it would work. So we've scheduled this item for an update and then some questions. I'm grateful to Charlotte Pomeray, who's the Chief Participation and Place Officer from NHS North East London, who's one of the 4 people on the executive management team, for joining us. Charlotte, if you would start off by maybe just giving us a brief overview as to where we are with the new structure, what it involves and what's different vis-a-vis the current structure. I appreciate there's probably still ongoing discussions in terms of jobs and things like that now. But I think one principal concern is, what does the place look like? What could Hackney Place look like at the moment under that new structure? So Charlotte, over to you.
Thank you very much, Chair. I'll start with a slight caveat in that we haven't made the progress that was anticipated at the point at which.
Sorry, just to pause you there. Guys, in the public gallery, please move quiet, please. It's very difficult to hear the guests when there's Yeah. If everyone is quiet in the public gallery, I think we all might be able to hear each other. So Charlotte, over to you.
Thank you. So thank you, Chair. So I'll start with a caveat that the progress we anticipated making when Zena wrote out to the system earlier this year has not been possible. That's because there has not been progress at a national level on identifying the funding for the redundancies required as a result of what you cited there, Councillor, as a significant reduction in both the head count for the Integrated Care Board, the ICB, and in its running costs. That discussion is ongoing, and we have therefore not been able to move forward with the consultation on the restructure as anticipated. So we're not quite at the place we thought we would be at this point in time, but I think it's fair to say there has been significant activity. I'll brief you on that, but I just thought it was worth mentioning before we go into what we're doing in the ICB, to mention that alongside the model ICB blueprint, there has been progress on a model regional blueprint, and that sets out how the region, so London region of NHS England, will operate. So what that indicates is that the region will take more of a performance management and oversight role. It will not be involved directly in commissioning, but in the future will take more of that sort of oversight of the system. It will have direct relationships with some of the providers in our patch. So for you, that's Elft and Homerton specifically, and for the ICB, it just confirms the role of Strategic Commissioner. So just a reminder of the model ICB blueprint. It focused on the role of the ICB as a Strategic Commissioner. For us, that means a proposal that our operating model brings together for North East London, a focus on commissioning. That's both a new approach to resource allocation, so making sure that we're using equity, addressing health inequalities, and our resources most effectively to meet the 10-year plan. As you highlighted, this was a significant document. It sets out not only for the next 5 years, but over the next 10 years, how we as a system, that's us in the NHS, but it's more widely across the system too, will make the strategic shifts from treatment to prevention, from hospital to community, and from analog to digital. Our operating model will focus the commissioning at a North East London level, with resource allocation, with data insights and strategy, and then with active commissioning, which will be supported by clinical commissioners. And that's important to us because we want to retain a focus on quality and patient safety throughout the way that we commission. We also recognise the really importance of the links to local places, to local authority strategic commissioning, and we see that strategic commissioning, while being focused on a North East London approach, will have its feet in place, if I can put it like that, and so have a really strong connectivity with local authority commissioning, for example, and with groupings of commissioners. So it might be for outer North East London or inner North East London, for example. We are folks, so that will be the sort of the strategic commissioning function. Our place function we see much more focused on delivery, and that'll be about delivery of neighbourhood health. That's really the driving force, one of the driving forces in the Integrated Care Board. It's a really important agenda for us in North East London more widely. As you know, in City and Hackney has been a strong and developing agenda for several years, and we're really keen to build on the progress that's already been made in City and Hackney. So building on that neighbourhood health model, our focus will be about place delivery. That'll be both about support to primary care, so making sure that our operational support to primary care is strong. Our work on medicines optimisation, so making sure we're using prescribing as effectively as possible, and then making sure we've got support on engagement with our local communities, work on babies, children and young people, and work on adults, which we see is likely to be focused around work on Better Care Fund, which is itself being reformed, so another whole set of changes to the Better Care Fund approach, again with a focus on neighbourhood health, special education needs and disabilities, for example, for the children and young people agenda, and making sure that we are an effective partner at place. The model ICB blueprint also indicates that over time, those delivery functions at place will transfer to a neighbourhood health provider. Now, that is not specified beyond that in the model ICB blueprint, but in the 10-year health plan, there were indications of a neighbourhood health provider, new contract arrangements for neighbourhood health provision, and we are actively working to understand what that means for us in North East London. We've also been working with partners, and some of them around this table today, on what the role of an integrator might be in hosting some of those functions for us in the ICB. Now, our capacity, clearly the headline figure at 50% reduction in both running costs and in our headcount in the ICB means that our capacity will look different, and the way we deploy our capacity and capability will look different for the ICB. That means it'll be differently scaled place teams. We are committed to teams in each place, however, and that's across North East London, with senior leadership as well in each place. That is a model we're really keen to promote in North East London, because place is such an important unit for us, both in terms of delivering, but also the close links we can have with partners and with the system. Equally, we believe that to deliver a neighbourhood model, you need to be feet firmly in the ground of your local neighbourhood, and actually already there are a number of layers, neighbourhood to place, to our system across North East London. And then we also have to work at a regional level to make sure there's some consistency for Londoners. I'm afraid, Councillor, I'm not able to give you the detail on the structure at this point. We've not been able to consult with staff to share that information with staff at this point, but I'm happy to take any questions. Clearly, there's, you'll be aware there's a huge amount of other activity in the NHS at the moment. I'm very happy to take any wider questions too. Thanks.
Thanks, Charlotte. I've got a few questions in the chamber. Just if I can just start off. So my understanding is that you've given us an overview, but there's not actually a formal document you can share with us yet, because that in part bound up with the staffing structure, and that needs to be presented to them first, as often happens. I understand that. But just picking up on one thing you indicated there, the place remains, but in due course, the idea is that is then transferred to neighbourhoods, if I understood correctly. So in other words, whereas we have the likes of Kirsten, who's overlooking a sense of place at the moment, in future, in a new structure, that role and our primary care lead in Hackney, and the fact that we may have enhanced services sort of on a borough level, in due course, you're possibly looking to that being delegated down to neighbourhood, so we lose the place-based level in the structure. I understood that correct?
In part, if I can say. So I think we are seeing only one neighbourhood health provider for each place. So we won't lose that connectivity with place and that overview. So it won't be every neighbourhood would have a different neighbourhood health provider. There will be a single provider across place that will support, whether that's an integrator or will support place. So that unit of place, if I can put it like that, will remain with that potential for an overview and connectivity between neighbourhoods. So it's not all delegated down to that micro level, it is also at a place level. And that's clear in some of the planning guidance that's come out recently, which is we're working to, even though it remains draft, where there is this indication that we need to develop what's called a neighbourhood health plan, but actually is a place health plan, which will be aligned to the Health and Wellbeing Board in each place. So there's quite a lot of moving parts, but a place remains. So we're not looking at multiple neighbourhood health providers in one place. I hope that's clarified.
That helped to explain it a little bit more. It's really just a brief comment before I go into others. I mean, we've obviously seen in Hackney, we often trumpet our model, but we think the evidence is we've been very successful as a place, both in terms of GP satisfaction, low call on 111, some of the best A&E attendances, all that data. And so if we were to dismantle some of that architecture, that could be very worrying. So I suppose my sort of comment to you as somebody that's looking, in part, designing this model as much as you can in that framework, is not to tear up the nuts and bolts that have worked successfully in Hackney, and to try and make it work in a way that's still both consistent with what you have to do, but also consistent with what you know works in this area. And because it would be a crying shame if that's all lost, just towing a line.
Yeah, I mean, Chair, if I can come back as well on that. So if I take the example of neighbourhood working, for example, there's quite a lot set out at a national level, there's quite a lot set out at a regional level, but our sort of starting point has been to build on what we've developed locally in North East London, and obviously much more locally in City and Hackney, where there's, that's probably the blueprint for us in North East London of how to effectively develop neighbourhood working. There's an architecture in City and Hackney which is different from other architectures. The role of the Homerton as a very much place-based provision, which differs from other places, for example. But there's certainly a lot to build on, and we're really keen to retain the strengths.
Thanks, Charlotte. So I saw Councillor Rathbone and then Councillor Lucas. Councillor Rathbone.
Thanks very much, Chair. I'd just like to echo the Chair's comments about we've got a really good working operational local model, which we don't want to lose. A media story on Friday stated that almost everyone who holds a position of influence and power in the NHS outside the provider sector is now either about to leave, uncertain whether they will have a job in a few months, about to find themselves with new bosses, or in a new job which they did not expect to be doing as late as last month or even last week. I dare say you may have seen that yourself. So how can senior NHS management seriously talk about expecting the NHS to plan for the medium and long term when staff face constant restructures and uncertainty? And I don't know if I misheard you, but I think you may have said at the start that the staff don't even know about this yet, which I find very surprising that, through a public meeting, they may very well find out rather than direct contact. I may have that wrong, so please do correct me. But I just really, 50% is huge, and I just wonder too, in connection with this, what kind of negotiations, discussions have taken place with unions so far? Thank you.
Charlotte.
Thank you, Councillor Rathbone, for your question. So just to clarify one thing, we have been talking to our staff consistently. We've had weekly briefings with staff. We have had departmental meetings to brief them on the operating model, the changes of the Model ICB blueprint. Everything that you have heard today has been shared with staff. What we haven't been able to share yet is the structure that we'll be going out to consult on, because that was subject to consultation. So just to clarify this, you know, I can see some of my colleagues on the call, Amy, for example, this is not news to Amy. I just want to clarify that, and we wouldn't use a public meeting in that way when we hadn't shared that information with staff. I also saw that article, which I believe was in one of the editions of the Health Services Journal. I think it reflects the level of change and churn there has been across the NHS, and this is another facet of this change. I think what the aim of the 10-year health plan is to try and sort of stabilise some of that change once it happens, to deliver a long-term plan. It's quite a challenging balance. You'll have heard around this table about financial challenges, about activity and demand increases, about how we respond to growing population, for example. But it's fair to say it is at the moment it is a challenge, and we are very aware that our staff, the level of uncertainty for our staff is very challenging, as we're not able to move forward into the consultation, which we were anticipating being able to start much earlier in the year. We have been briefing and working closely with our local trade unions, and in the way that we've briefed staff, have been keeping them involved in our process, in our approach. And that's across the range of unions involved in the NHS and the ICB in North East London.
Thanks, Charlotte. Councillor Lucas.
Yeah, thank you, Chair. I mean, that was a really helpful update, Charlotte. And my question really builds on Councillor Rathbone's, just around, you mentioned that the structure consultation was kind of stuck in limbo at the moment, and you were waiting for that to be unblocked by the powers above, so to speak. So when is your ambition that that does go out to consultation then? Can you give us a sense of timelines and what representations are being made to those who are kind of blocking it at the moment, and what work is being done to sort of unravel that, so we can get this moving forward and provide that clarity that everyone's looking for? Thank you.
Thanks very much, Councillor. So we are needing to work in lockstep with our colleagues in National. So when I'm not able to give you a definitive timeline, our commitment to our staff, however, is that we will, from whenever we are given the go-ahead to go out and start consultation, that we will allow at least 2 weeks notice for further engagement, for discussion, and before we launch the consultation. So that has been welcomed by staff, so it won't be like hearing one day from National and then straight in the next day. So that's the commitment we've been made. We're not, the timeline is out of our hands locally, and therefore I'm not able, I do regret, Councillor, but I'm not able to give you an update of further detail on that position at this point.
Councillor Adams.
Thank you, Chair. I've got 2 questions. The first one, how does the new module align with the National ICB blueprint published in May? That was my first question. And the second one, how will local communities be involved in shaping these new place-based arrangements? Thank you.
Thank you, Councillor. So the operating model that we have developed is very much based on the Model ICB blueprint. We have been through an assurance process with our colleagues at NHS London region to ensure that there is a connectivity between the model blueprint and what we're proposing from an operating model perspective. And so our structure reflects the requirements set out there. As you may be aware, there are some elements in that Model ICB blueprint which require legislative change, for example, any changes to continuing healthcare or to safeguarding responsibilities, for example. So those, we are retaining those functions, even though they're not set out for long term for the ICB. And there's been quite a lot of conversations at a national level around those particular functions. In terms of local community involvement, we have shared our operating model widely. We've, in terms of place developments and the neighbourhood health model, we are involving local communities in the development of that. We're aware there are sort of significant changes in the engagement functions set out also in the patient review published soon after the health plan, particularly to the role of Health Watch, which we have some concerns about. So yeah, there's more work to do on that place, but the neighbourhood health model in City and Hackney and indeed across North East London reflects the involvement of our communities, those who use our services, and indeed those who for whatever reason don't use our services. So I'm really keen to continue that model of engagement as we develop and go forward.
Thank you. I know Councillor Turbot-Lord, but Dr. Kirsten Brown waiting for us. I'll bring in Dr. Brown and then I'll come to Councillor Turbot-Lord. Kirsten.
Thank you, Chair. For those of you who don't know me, I'm Dr. Kirsten Brown. I'm the Clinical Director for City and Hackney Place-Based Partnership. And I just wanted to come back on the matter about place. And just all of us who are working at City and Hackney level, at the place level, and all the partnership organisations are very committed to continue to working in a partnership way. So I just wanted to reiterate that there is certainly still a big part of the system which will operate on a place level, and all organisations are within our place-based partnership are committed to working in that way to deliver our healthcare services on a neighbourhood level. So just a real commitment from all our services that we will continue to work like that and involve our residents in the development of our integrated neighbourhood teams going forward.
Thanks, Kirsten. Councillor Turbot-Lord.
Thank you, Chair. Thanks very much for the update, Charlotte. It's really helpful to hear. I think there is a theme around community, isn't it, that we will coming back to. But I think definitely it's clear that there is a lot of uncertainty and genuine concern around these new restructures. I just wanted to ask whether you also see some real opportunities emerging from this. I'm particularly encouraged to hear about the focus on community service or services coming back to community. Are there maybe plans to review what might not be working? I know, and I can see you nodding, which is great. I know, for example, I'm a big campaigner for mental health, and places like talking therapies that have quite high dropout rates, for example, which work but do have high dropout rates, for example. Are we thinking about repurposing those funds, going back to the communities, to projects that really struggle with funding, but that do so much for the local communities' mental health and well-being? Thank you.
So thank you, just finding mute. Thank you very much for your question. Really, really important. I guess a couple of things. One is that despite the reduced capacity that we will see into the future and the numbers of staff we're able to employ, there are some huge opportunities in the agenda, as you've highlighted. That real, you know, as Kirsten was saying, a really strong focus on neighbourhoods, on working earlier with people, like doing more, putting more into prevention, really building our community and primary care capacity, which is already very strong in terms of primary care in City and Hackney. So there are some really significant opportunities. Equally, that capacity point and the wider financial challenges also pose some challenges to us as a system. But yeah, I wouldn't underestimate the opportunity in those three big shifts. I know they're at a headline level, but if you start to unpick them and what they might mean for local people, it's about in effect improving their access, experience and outcomes of health, and improving their health and wellbeing outcomes, which we're really keen to see. In terms of review, so alongside this work, we have just undertaken the first phase of a process of refreshing our commissioning intentions, and some of those very much focus on community, focus on mental health, focus on where our resources need to go to meet both those big three shifts, but also what the needs of our local population are telling us across North East London. So there are some opportunities set out in those summary commissioning intentions, which over the next few weeks and months to the end of the calendar year, we need to turn into commissioning plans, and which our partners in Elft and in Homerton also we will work together to develop some integrated delivery plans. So I completely agree there are some opportunities, and it's good to focus on some of the positives, but it is also quite a challenge to balance the different agenda at times. So thank you for the question.
Thanks. Councillor Kennedy wants to come in.
Thank you. Yes, Councillor Kennedy, Cabinet Member for Health, London Borough of Hackney. I was going to mention the commissioning intentions that Charlotte has just mentioned, and point out that don't get the impression that there are a load of people sitting doing nothing, worrying about when they're going to find out about the restructure. There's an awful lot of work going on at the NEL level. We've been sent through the draft health strategy that we're going to look at our November ICB board, and then also at the local level in terms of getting the feedback, especially from partners, from representative patient boards. We've got the first ever joint meeting of the Health and Wellbeing Board for Hackney, the Health and Wellbeing Board for the City of London, and the City and Hackney Health and Care Board, so our place-based partnership, and that's happening in a couple of weeks' time. So it really does feel like the system and partners are coming together and rising up to the challenge that reorganisation is bringing.
And Councillor Kennedy, I mean, obviously, you know, the ICB structure has to give effect to what it's being mandated to by the Department of Health and nationally. I understand that, but within that, how much scope is there to have flexibility, to have systems either that we know work and keep those going, or to make change, or to have a system that works for the local community in a way we know, or is it very tramline based and there's not that much flexibility there from what you've seen? How much can we make this work for Hackney?
It feels like it's an opportunity locally, and there's quite a bit of give, and that actually, given the very strong position that you're already in Hackney, with really good primary care that works really well, consistently performs, all our primary care measures outperform the rest of the North East London system, and those guys are stepping up to the plate and going, let's use this as an opportunity, keep hold of all the good work we do, shape it ourselves. In a way, if the big management centre has got half the people, it's got half the time to tell you what to do.
Putting a positive spin on it. Councillor Adams, last question.
Your Chair. So I was just wondering, will the ICB retain flexibility in budget management under the new structure?
And Charlotte, just to piggyback on that, is 80-20 dead? 80% going to place, 20% at ICB?
So I'll take the first question first. Yes, we retain, there are some shifts in the financial management, but all the commissioning budgets for North East London come through the ICB, and our requirement is to manage that as a commissioning budget. What changes is that our current role has been to hold what's called the system total. So the total budget spend, if providers are in an overspent position or an underspent position, to try and keep that balance. Our future role will be just to keep our commissioning budget, which is significant. It's well over £6 billion for healthcare across North East London, in balance. So that is the shift which we'll be working with providers, working with the region on over time. I think it's fair to say, Chair, that we probably are going to revisit the approach, partly because we have other flexibilities and freedoms we can use. The resource allocation will look different. Our ability to meet the big three shifts will look different. Our contract and payer mechanisms are, being promoted as different. There are elements such as, which I hope isn't going into too much detail, but deconstructing of block contract arrangements that mean it's quite hard to have a huge amount of detail about how money is being deployed. So there are some opportunities in that space, and I suppose what we're keen to do is make sure that those three shifts, which do focus on neighbourhood and place, are affected over time.
Thank you very much, Charlotte. Oh, I see two members that haven't asked questions. I'm going to very quickly take them together, and then I'll go to Councillor before, please, first.
Yeah, thank you, Chair. I think 50% reduction seems a big, huge kind of an impact on restructure and enforced restructure. But going forward, do you see it like, is it going to enforce more online kind of approach to address some of the issues that you may encounter? And have you also engaged with the union as part of the process to ensure every kind of litigation is being addressed in terms of 2P and kind of stuff?
And I'll take Councillor Adebayo at the same time, please.
Just similar question, because 50% is a huge reduction. And my concern is, how are we going to make sure we're not going to lose some of our valuable staffs in the process of restructuring?
Charlotte, if you just take those last two questions, please.
Yeah, thank you. So I mean, 50% is a significant reduction. It's not something where you can just sort of make a few adjustments and tweaks to the model, and which is why we've done some work on the new operating model, and our structure will need to reflect that. We fully recognise that is quite a significant change. It's not something we initiated locally. Obviously, it's something that is a national requirement, and is a way to sort of create some headroom to do some of the other things that the NHS wants to do. In terms of the online point that you made, Councillor, one of the big three shifts in the health plan is from analogue to digital. So there is a view that there is more work we can do to optimise the opportunities of digital, of online, but that shouldn't be at the expense of making sure that people can access face-to-face all the sorts of services that they need to. And just to reiterate, we have been engaging with trade unions throughout the process. Thank you.
Thank you, Charlotte. I'm going to draw it to a close there. I think this is an obvious item to come back when you're in a position to share what that structure would look like. Obviously, it impacts upon Hackney in terms of joint roles, such as the Director of Partnerships. I know Amy's on the call, just for us to understand that. It understands in terms of the City and Hackney Health and Care Board, where that fits in. There's all these sorts of things to fully understand what that structure would look like. But I thank you for your time. I think you've got our sort of input in terms of, you know, the pride we take in our place. And what we've achieved, and if that can be maintained where possible in this new structure, it's a plea from us.
Yeah, thank you, Chair and Councillors. That, I mean, obviously reflects the significant partnership working, the real strength in collaboration, and the excellent work that happens in City and Hackney, from primary care through to our acute services. So, you know, we need to retain and build on what we've got locally, despite the challenges ahead. Thanks.
Thank you, Charlotte. So I'm going to bring that item to a close. I'm now going to move on to item 5 on the agenda, which is in relation to the soft facilities management contract at the Homerton. We're joined by Tom Nettle, who's the Deputy Chief Executive at Homerton Healthcare, and Lou Wee, who's the Chief Financial Officer. Welcome to both of you who are joining us online. Just to quickly counter through the background to this, the soft facilities contract deals with porters, cleaners, security staff. It came up for renewal a number of years ago. There was concern of which this committee held a meeting in terms of parity of contractual rights of those members that were working for them. And after, I think, some discussion, the Homerton agreed certainly to fund ISS, who was the contractor, in terms of better, I think it was sick pay as being one of those areas. During the interim, we've had BARTs going out and bringing those services in-house, and we've had various discussions with the chief exec over the years about the possibility of whether, when Homerton's services came up for renewal, whether they could be brought in-house or whether BARTs could play a part similar to the one that they took for their own hospital. as I understand it, we're going to get an update today, but as I understand it, we're going out to Homerton's going out to open procurement, which I understand, Tom, if you're leading on this, that what that means is you may or have, please clarify, ruled out either insourcing or working with BARTs, but you're going for a fully open procurement process. But I may be wrong on that. So that's sort of the backstory as I understand it. But if I can go over to you for an update, please.
Yeah, thanks, Ben. I'm actually going to hand to Lay, who is going to cover this item off. Thanks.
Thank you, Tom, and thank you, Chair. So just I'll start with a recap of a bit of history. So following an options appraisal, Homerton Trust Board has taken the decision in January this year not to insource the soft FM services. This decision was informed by internal assessment of a financial and operational feasibility, engagement with our local NHS organisations and the local authority, with written responses received indicating that none of these organisations are actually able to take on additional financial and operational risk to run these services. So given this, the Trust Board has agreed to proceed with a fully compliance procurement process, utilising a NHS soft FM framework under the Public Contracts Regulations 2015 to identify a new provider. This procurement will consider alignment with the NHS terms and conditions through both qualitative and quantitative elements to the evaluation in response to the concerns raised by our key stakeholders, especially from the staff side and this committee. So where we are now, we're currently just carrying out active engagement with the key stakeholder groups in relation to this re-procurement, including our Council of Governors and staff side representatives. This process is tailored to each stakeholder group, recognizing their respective roles and responsibilities, and we will ensure transparent, appropriate, and effective involvement of each stakeholder groups. And through the scheduled workshops and sessions during this engagement, the feedback and suggestions from the key stakeholders will be integrated into the procurement framework. And we will, of course, continue to update this committee as needed or required. Okay, that's the latest from us. Happy to take questions. Thank you.
Thanks, Lai. Can I just ask then, in terms of if you're considering financial alignment of terms, presumably, and correct me if I'm wrong, that can't be financial alignment of all terms, because otherwise it would just be as cost effective to bring them in-house. So presumably that would be a financial alignment of some terms, but not all, because otherwise you'd be bringing them in-house if it was exactly the same. So roughly where, I'm not, in asking this question, we as a council are under immense cost pressures as well. And so I understand, I'm very much understand the pressures you are under in this regard. But just for transparency and understanding, where would the areas not be of alignment? Would it be in pension rights principally, or would it be in sick pay rights? What would be the areas where you might be able to bring more into alignment, but what would still be out of alignment?
Thank you for the question, Chair. So we are currently, as mentioned, carrying out the engagement, making sure we hear from our key stakeholders to frame the evaluation criteria. These staff terms and condition will be an important part of the evaluation criteria. So given we are in the middle of the procurement, in the middle of the pre-stage of engagement, there's a lot of commercial sensitive information we probably won't be able to share at this stage, but I can give the assurance that the staff terms of condition will be properly considered and fully embedded in our evaluation criteria.
Okay, thanks. I mean, it may well be that when that's in public knowledge, or whether it's further evolved, we can actually have more clarity on that. I've had a number of hands.
Can I just add?
Oh, sorry, go on, Tom.
Sorry, can I just add to that? I just want to highlight, it's not necessarily the case that the only if we had exactly the same terms and conditions, we would have therefore automatically have considered in-house. There are benefits to outsourcing in terms of scale, in terms of resilience, in terms of being able to draw on a much larger group of professionals that can provide services that outsourced offerings provided. So I just wanted to be clear, it doesn't, just because we would offer the same terms and conditions, that doesn't mean we would therefore automatically have considered in-house, and that's the only option. There are real benefits to an outsourced option in terms of scale and resilience that are worth emphasising, just in terms of how we are thinking about it. Does that make sense?
No, it does, and that's a valid point, Tom. I understand that point, because clearly, if you have got that scale, then perhaps you don't need more localised managers or what have you. So I do understand. That. It's just, I suppose, in due course, it's just transparency. That is it the case that it is complete parity of terms across everywhere, or are there some areas where it hasn't? And also from your point of view, if it were to be complete parity of terms, a lot of people's concerns would be negated, and that might resolve the issue. So it cuts both ways as well in terms of that. So in due course, it's just transparency on that. Now, I've seen lots of hands. I think Councillor Rathbone, was that a legacy hand from you? No, sorry, Councillor Rathbone first, then I'll go round.
Thanks very much, Chair. I mean, these are people who are some of them are quite low paid, aren't they? And you know, it's really important that we get this right. So I just wondered, what's been the outcome of discussions with the unions? That's an important part of it. And does this mean that ISS, the current contractor, is likely to continue to play a part? And what ways have you amended the design of the service and therefore the spec? Thank you.
Thank you, Councillor, for your question. So, as mentioned, the board has agreed that this procurement will be conducted under the NHS Soft FM framework. So, all the providers registered under that framework is eligible to put in their bid when the tendering document is available on the market. So we are, as mentioned, we continue having the conversation with the key stakeholders, finalizing the criteria, and we're just in the middle of the work, finalize the details. So it's quite hard to give the specific details on your question.
And just in terms of liaisons with the unions?
There's ongoing conversations with the staff side representatives, and we are the plan is for the engagement to carry out throughout September till November and early December time.
Councillor Turpin-Love.
Thank you, Chair. Thank you so much for the update. Many of these soft facility management staff at Homerton are cleaners, caterers, and porters, have now been waiting quite several years for the outstanding COVID payment they were promised, and which I'm sure you're aware of. I just wanted to know what assurances are these workers going to have in this new contract that is coming up. And also, it would be good to hear, you mentioned key stakeholders, which is great, you're engaging with them. Trade unions, I'm sorry if I didn't hear because the sound is a little bit funny here for me today with my new headphones. But did you say that trade unions are key stakeholders, and are you meeting them? It would be good to hear the involvement with trade unions. Thank you.
So as it stands, we're talking to the representative from the staff side, I think on a monthly basis, if not actually more often. And then we're open to the challenge and open to their views and thoughts. We also have a regular conversation with our Council of Governors, which have close link to the staff representatives and the frontline staff members. So we are hearing people on the front line, their views and thought, and embedded this into our evaluation process.
Thank you. Did that answer all your points, Councillor Turpin? Or was there a point that was
curious about the COVID payment, especially,
so
which has been ongoing for years, as you know.
Question about historic.
Yeah, I probably should take that. We have been clear about this in previous governors' meetings and elsewhere that the COVID payment doesn't apply to anyone other than directly employed NHS staff. That meant it didn't apply to temporary workers as well as outsourced staff. We weren't funded for this, and we have been clear, Chair and Councillor Turbot-Delaf, that we were not in a position to have made that payment. We've set that out before categorically, and that position sadly won't change.
Yeah, and I suppose, Tom, that's a bit like that. Actually, what your point there, as I understand it, is that was a national decision,
national decision,
which you weren't funded to do. So it's a bit like the government saying the council's got to do something but not fund it, sort of thing. You know, it's that sort of analogous situation.
It is exactly like that.
Members, any other members for questions on this item? I'm looking around. No. Well, in that case, then, thank you both for the update. And I think an obvious point is the point when I appreciate throughout this process there will be some degree of contractual sensitivity. I get that. But that at some stage when it's understood, I think what principally concerns people is the parity of contractual terms with NHS staff. And if it's not, which bits aren't, and then obviously, if that were to be the case, that there may be financial factors you're relying upon for why that is the case in the budget scenario you're in. But just for transparency, I think that's one of the key concerns, that when you've settled on a position there, for there to be at least transparency in relation to that. And so at a point in your cycle, it may be January, it may be February, I don't know, it may be a bit later. It'd be a suitable item for this just to come back and understand what exactly you were going out to procure on those terms. So there's just greater transparency on that. So and with that sort of suggestion, I'll draw that to a close at this stage, unless there's anything either of you want to say.
No, I think I'll absolutely take on this on board. As soon as those information could be made public available, we will bring it to this committee for, as you said, for the transparency sake and for further discussion. Thank you.
No, and thank you both. And we do appreciate, you know, as I indicated before, we do appreciate as a council we're under similar financial pressures, and we do understand the financial pressures you are under. But at the same time, we obviously have concern for the workforce. But thank you both. I'll bring that item then to a close, and then I'm going to move on to item number 6 on the agenda, which is the integrated neighbourhood teams in City and Hackney. We're joined by Dr. Kirsten Brown, who's already introduced herself as the clinical director of a City and Hackney place-based system, by Dr. Khan, who's a GP at Spring Hill Practice, and also the clinical director of the local PCN there, and the City and Hackney Neighbourhoods clinical lead, and also by Dr. Stephanie Coughlin, who is now the Chief Partnership and Place Officer at the Homerton. We're grateful for the presentation in the agenda pack in relation to this. We've obviously got neighbourhoods and PCNs sitting on sort of coterminous blueprints, and just to try and avoid confusion, as I understand it in crude terms, neighbourhoods is more about joint working of different partners, adults, children's, pharmacists, etc., possibly bringing services in the hospital. PCNs has historically been about groups of GP surgeries working better together. So that's to avoid any confusion, that's the rough framework as I understand it. Kirsten, over to you, I think, to give us what the next stage in the 10-year plan, what it might look like with the new neighbourhood model.
Thank you, Chair. I'm going to just do a bit of an introduction, and then I'm going to hand over to Dr. Taseen Khan, who's our new clinical lead for neighbourhoods, and he'll give more detail about the future of the programme. As we've already heard this evening, the NHS 10-year plan has a real emphasis on neighbourhoods and care closer to home. And our work in City and Hackney as a place is going to be very much based around integrated neighbourhood teams and working on a neighbourhood footprint going forward. And obviously in City and Hackney, we've had a neighbourhood programme since 2018. So in many ways, we are really ahead of the curve in terms of neighbourhoods compared to many places nationally. And we, as you've said, we have got services such as our primary care networks, our community services, our mental health services, our social care, all aligned on a neighbourhood footprint already. And lots has already been done around integrating those services. However, we also appreciate there's a lot more to be done. And I think for me, the two main focuses going forward is really going to be about delivering true integration on the front line of services around a patient. And that will happen on a neighbourhood level. So although we've got all our services aligned at the moment, I think there's a lot more that can be really done about true integration. And then the other thing that I think we really are going to have a focus on, and I know Dr. Khan is very passionate about this, is the use of population health data to really, really drive meaningful change for our patients and make sure that we are trying to address the health inequalities that we all have, but we certainly have in City and Hackney. So I'm not going to say any more. I'm going to hand over to Tahseen to take it further, to give more detail.
Thanks so much, Kirsten, and thanks for having me here today to talk to you about City and Hackney neighbourhood. So, as Kirsten said, my name's Tahseen. I'm a GP at Spring Hill. I'm clinical director there, and I've just been appointed as the clinical lead for City and Hackney neighbourhood. So, my aim today, obviously you've got the pack, is to go through the key points around where we are currently in terms of neighbourhood, both from a NEL perspective and nationally. But also, I guess, reflecting on some of the work that has been done in City and Hackney, some of the really innovative work that, as you heard earlier from Charlotte, is actually turning into a bit of a blueprint for NEL, and actually wider than that to be delivering neighbourhood services. So I think we start from a very strong position, and I think that's important to remember throughout the next few years. I think we're really lucky to have those relationships and those neighbourhoods, even the footprints already established, which some areas are only just establishing. So we start from a strong position. And as you know, we have 8 neighbourhoods across City and Hackney. And the aim of neighbourhoods, since they were developed in 2018, is to focus on integration and preventative care, so that we reduce some of the reactive and unplanned and emergency care that we see through the system. But as well as that, it's to connect with and understand our population health, so that we deliver services on a very hyper-local level. So, for example, the primary care network, which I've led for the last 7 years, is in the north of Hackney. Springfield Park is a very different area to South Hackney. A lot of our population in the north is under the age of 18. One of our 3 practices, 50% of its population is under the age of 18. And at any given time, around 12% of our population in the north is pregnant. So it's a very different healthcare ecosystem to the rest of Hackney. And therefore, having that hyper-local variation in services, whilst making sure there's equity across City and Hackney, is really important. And with that, in that respect, we've done some significant work since 2018 to make sure that we structure both our adult services and community services around that neighbourhood footprint. But as Kirsten said, the next step is to really develop the integrated neighbourhood team model that is now nationally mandated from everywhere in the country, and so that we are able to better reduce health inequalities on a local footprint, and also improve population health using the data and the assets that we have. So our case for change really is what it was back in 2018, which is around the workforce and sustainability pressures that we have and continue to have, and will probably continue to have for the foreseeable future, as well as the rising levels of comorbidity, with 30% of people living with one or more long-term condition by 2040. In the context of growing pressure on all services and people having worsening health outcomes and some of the wider determinants of health around housing, around financial pressures actually being worth, certainly as a day-to-day consultation in my practice, I see more and more the impact of some of the financial pressures that people are faced with, and some of the housing issues that they have, and the impact that has on the health service. So with those challenges, and in the context of City and Hackney being a very deprived borough, but also a very young borough, we had set up neighbourhoods with the idea of connecting communities to address some of those health inequalities based on the data, and to deliver some of these particularly complex care to our most vulnerable residents in City and Hackney, so that we give them care closer to home, and we give them the care that they deserve, whilst looking at other cohorts within City and Hackney as well. So we know that City and Hackney neighbourhoods, they are the essential points at which we deliver care, and we have very, as I mentioned, very well established neighbourhoods with primary care providing some of the clinical leadership, but also some of the roles around additional roles funding, which primary care networks have invested into the neighbourhood model. So that involves having, lots more in our network. For example, we've got 25 additional staff compared to in 2019, where we've got physiotherapists, paramedics, wellbeing practitioners, social prescribers that look at health more holistically, so that we can address what matters to residents beyond just traditional kind of health and social care matters, whilst actually giving patients the option to have the care that they need, so that if they have back pain, rather than seeing a GP who might end up referring them for physiotherapy, they directly can book in to a physiotherapist within a GP surgery. So it's about providing that care closer to home, and providing care that's appropriate for that patient. And we've got three main aims around neighbourhoods. So the first one is to connect local communities to address health inequalities and promote health and well-being. And we do that because of the structures that we have. So we've got very well-established neighbourhood forums, which our voluntary and community sector lead, and that provides some of the insights that comes to the neighbourhood leadership groups. And we've actually managed to mobilise health inequalities funding that comes from the NHS based on some of these insights, with the neighbourhood forums and the neighbourhood action groups that exist as part of the forum within a neighbourhood. And I think that insight is really valuable. Certainly, I mean, giving an example of North Hackney, we, as you know, have a huge challenge with childhood vaccinations, and it's because of the neighbourhood working that the links between our healthcare, our acute sector, public health, involving UK HSA, the Health Security Agency, we were able to mobilise very quickly additional clinics to respond to local needs in North Hackney, and that's led to, since the measles outbreak in May 2025, we've managed to deliver around 2,700 vaccines by having that partnership approach with residents. So we test everything with our residents. All our comms that we put out into, for example, the Orthodox Jewish Press, but also the general comms that we put out, is tested with residents, is co-produced with residents. And we also, when we were planning our clinics, we were asking residents where do they want those clinics to be. So we have the Lubavitch Centre, for example, where a lot of the Orthodox Jewish community go to. We also have done pop-ups around health centres across the north of the borough, and even into Haringey. So we have that very much that resident in the heart of everything we do that helps drive all our services. And I think the plan is that we're going to continue building on that, building on our relationship with the community, so that we can get the insight and it actually drives our intervention. Because I think, that's why we're here, that's why we're doing the job. And I think certainly since COVID, that has been the emphasis, has been around reducing some of the hidden inequalities that previously the NHS and other services just failed to recognise and failed to address. So that's my passion in terms of why I took this role and how I see neighbourhoods developing.
Dr. Khan, I've got some questions I think wanting to be asked. Is it okay if I just wrap up maybe in the next minute or two, and then I can go open to questions if I can?
Absolutely, yeah. I mean, I can give an overview of what our plans are over the next immediate term, and then into 2026, 27. So we are recruiting a new team of. So obviously, I've been recruited as a clinical lead, and then we're going to have a head of neighbourhoods, and then some neighbourhood managers. So there'll be 4 of those. And then the key thing is we're going to use that data, the population health insight. So we've got a tool to be able to do that at hyperlocal level that draws on acute sector, primary care and social care data that allows us to look at our baseline of where the need is, but then also monitor any interventions that we do. So we're really excited to be one of the pilot sites for that across now. And then looking at delivering our multidisciplinary meetings so that we do look at our most vulnerable residents, but also actually how can we tailor some of those multidisciplinary meetings around frailty or proactive care. So we are getting in there earlier rather than waiting until issues crop up and people end up in A&E. So that's a key kind of priority. And then into 26, 27, the key focus is to strengthen some of those relationships, both within the community and across the professionals and the acute and the health and care sector. And then using that two-way dialogue with our communities to A, gain insights, and B, deliver services that actually matter to people, working with the population to help reduce health inequalities across all the neighbourhoods in City and Hackney. So I'll leave it there and leave time for questions. Thanks.
Thanks, Dr. Khan. I've seen several questions. Councillor Patrick hasn't asked a question yet.
Thank you, Chair. I personally think the neighbourhoods work well. The Hackney Marsh neighbourhood works well. I've been to several of its meetings, and tomorrow we've got a public meeting on pain management, which I should be attending. We had a great wellness day back in September. So I'm aware of some of the things that are going on in the neighbourhoods. But I'd like to ask a question about how you're going to integrate with the council, especially around IT systems. We heard a recent meeting on our transforming about all the work the council's doing around digital and using IT and to enhance the life of our residents and to make sure that they're safe and that they're well at home. There's been a long history of the council developing IT programmes and the NHS developing programmes, and the two shall never speak to each other. I just wondered how you're going to work on both the IT front to make sure that any system that the NHS uses and any system that the council uses meet each other, because on the whole, I imagine a lot of the people you'll be reaching out to will be the same people. And if we're to have an integrated neighbourhood with integrated services, and the council and the NHS and the councils and all the providers in the voluntary sector need to be able to talk to each other at the same level. Thank you.
Thanks. It may have something to do with our next item as well, but Dr. Khan.
Yeah, I mean, I completely agree with that. It's interesting you talk about sort of council data, but actually even within the NHS, actually until relatively recently, different NHS organisations struggle to communicate with each other. We're lucky now we have a system called Cerner, and that allows us to have a look at what's happened with patients across different hospitals across London. But I think this interoperability between organisations and the different governance that the organisations have is a challenge that we need to overcome, so that patients and residents aren't telling their story multiple times. I think there are solutions in development, and there have been some of this coming through into, for example, the GP record. But I think there is a way to go with that. I mean, that's why I'm also quite excited about this Optum work, because actually for the first time that will draw on local authority data as well as health data. So actually that will give us a good dashboard that will integrate both of those components. But I completely agree.
Councillor Lucas?
Yeah, thank you, Chair. Thank you so much for the update. It's great to see the work coming along. And again, that sort of piece around Hackney leading the way is really reassuring and good to see. I think the council's doing some great work around the voluntary sector and supporting it. And I saw in the slides actually that this is obviously a big part of the puzzle. I think you mentioned social prescribing and working really in an integrated way with those who are sort of in the field and in the community already. How are you promoting that resilience, and how are you working with partners? And then, if I may, just on actual space, I think you mentioned how logistically you were kind of, doing the pop-ups and going into the communities. Like, has that added extra complexity, and how are you sort of managing that process? And will there be enough space once the model is fully integrated, for example, in the sort of, in the pharmacies and the GP practices? Will they be the hubs? How's that going to work in terms of getting everyone sort of in the same place, partners and all? Thanks.
Yeah, I mean, I think, first of all, your first question about how we work together, and I think there's the kind of governance structure across neighbourhoods. So we have a leadership group where all the key stakeholders on a neighbourhood footprint meet every month. And then we decide the priorities based on what the neighbourhood action groups and the neighbourhood forums bring to that. So there's a regular update there. And that helps drive some of our priorities. And we've been lucky to get 3 years of recurrent health inequalities funding to then mobilise some of the projects that have come from the forum, the resident forum. So that kind of working has been working really well in City and Hackney. And I hope that we are going to have a bit of a refresher of our leadership groups and how we can make them even more effective. Secondly, the pop-ups. I think, again, this was, we've been doing childhood immunisations at a PCN footprint or neighbourhood footprint since 2022, and we've learned a lot along the way. And I think COVID definitely taught us how to be more agile and deliver care where actually, I remember doing pop-ups in a synagogue, in a mosque. I remember going to a construction site and doing it in just the open to a group of builders. So, that I think taught us how to take care to residents where they need it. And I think that's the key thing, that the insights and having that close link with our communities provides us, is actually where is it that's convenient, that can help then build a trust to services, whether it's vaccinations or accessing a GP appointment, for example, because actually we know that amongst some of our diverse community, trust is not there. And so I'm quite passionate that we take care where it's needed to our residents rather than ask them to come where we are.
Thanks, Dr. Carr. I saw, I've got other members, but I've seen Dr. Coughlin and Dr. Brown. And just bound up with that, I don't know if any of you sort of know the answer. I mean, at the moment, under the 10-year plan and the blueprint, is more money being allocated to estates for primary care to address some of those estates challenges, or is that too early to say? But Steph, I think you had your hand up a while back. If I go to you first.
Yeah, thanks very much, Chair. So I think just picking up on the estates piece, we know that there's a national programme around estates, and there will be some national monies allocated. But the initial understanding is this is likely to be outside of London, rather than within London, to areas that are particularly isolated and have very little. I think that's probably picking up on that point. Another point I wanted to pick up was just on the digital piece. We've actually started some work across all partners in City and Hackney, working with UCL partners. They're our innovation partner in North East London, to look at exactly that. What are the resources, platforms that we could be using, and what's the need around that, particularly from a multidisciplinary team working. So this is quite exciting, and building on some of that work, so that, if and when in the future there are then decisions to make around digital tools and offerings, that were really set up for that. And I think the other point I was just going to make was just building on some of the things that were discussed in Charlotte Pomeroy's discussion at the beginning, was just around, actually, we've been doing neighbourhoods since 2018. There's a massive commitment from all partners working in City and Hackney. And I think it's really, how do we use the national momentum to sort of leverage and harness what we have, protect it and build on it? We know that we are a forward-thinking area with innovative solutions, and it's now just really how do we take that to the next steps, both across our IPC, our Integrated Primary Care, East London Foundation Trust, Homerton, LBH, City of London, and our VCSE partners. And I think it's actually really exciting to have that national momentum around us. Yeah, so those were the points. Thanks very much, Chair.
Thank you, Stephanie. Kirsten?
So I think Steph has covered off the bit about estates, which is really looking at our estates will be a vital part of how we work going forward in the community, and that will have to happen as we see them shift from hospital into the community. And we will need to make sure we're utilising all the assets we already have. But I also wanted to pick up on around the voluntary sector and how they are such an important partner in our system and at a neighbourhood level. And you look at our projects like the Together Better project, which is the voluntary sector working in our GP surgeries to provide care to our patients, but through volunteers coming from our residents. And it's an amazing service, and this is just to demonstrate some of the work we've done on a neighbourhood level and some of the care that we can provide through the voluntary sector. So just to emphasise, they are a really important partner for us and will be an important partner going forward in terms of neighbourhoods. Thank you.
Thanks, Kirsten. Time's going on, so I'm going to take questions in two. So Councillor Adebayo and then Councillor Turber-Dillon. So Councillor Adebayo first.
Thank you. Just wondering, with the integrated neighborhood team approach, just wondering where the head of NHS sit on this, and will she be leading the project? Thank you.
Thank you, Chair. Firstly, just want to commend the work of the neighbourhood team because it's really fantastic. The neighbourhood forum those sessions are absolutely packed, whoever has gone to those sessions. It's an incredible place for residents to meet, to connect. I know that residents in my work have been they really rely on those sessions, so really, really good work. Something that is quite clear in those sessions as well is that young people are not attending in big numbers. And I remember in one of the sessions I attended, the feedback was given from youth workers and saying how else can we improve this. So just on the updates that you gave us on how you're working towards the developments that are happening, how do you plan to perhaps engage a bit more with the young population of Hackney in this process? Thank you.
Dr. Khan, do you want to take those two?
Yeah, I mean, firstly, the question just now, I mean, I think it is a challenge. We certainly see it in our patient practice groups that actually the people that come to a practice forum, a practice space, not just a neighbourhood, tend to be from a certain demographic. They tend to be older. They tend to be relatively well informed about their health. And the challenge has always been, how do we engage those people that might be time poor, that perhaps we don't see as often? And I think the key thing is we need to look at the channels that we use. Actually, is it convenient for young people to come and attend in person? Is there a way of allowing the younger people to engage with these fora more remotely, or actually can we get insights from younger people? Because actually the behaviours of younger people is very different to how I behave, and equally from other generations. So actually getting that insights about what makes people engage with health services is really important. I think that's something that certainly our behaviour scientists may be able to help us with, around what motivates people to attend and engage with some of these services.
I think Councillor Adebayo's question on, if I've understood it correctly, where does the NHS sit in the framework? I mean, as I understand it, Dr. Khan, is obviously everyone's under the NHS umbrella, but the neighbourhoods network is to try and pull together both NHS partners, say at a GP level, with maybe adult social care workers from the council, youth workers from the council, sitting on multidisciplinary teams, possibly pharmacists. There might be outreach work from the hospitals, instead of people having to go to the hospital. So I suppose you're pulling together key NHS personnel, as well as, say, council employees and other stakeholders. It could be a housing member as well. So I sort of think that's probably the best description there. Councillor Adams, did Councillor Rathbone, did you have a question as well? Yes, so Councillor Adams, Councillor Rathbone, and then I'm going to wrap it up, I think.
Thank you, Chair. Actually, I got two questions. The, the first one is how does this model differ from the previous community health integration initiatives? That's my first question. And the second one, how will success of this model be measured? What indicators or KPI will be used? Thank you.
Mr. Rathbone?
Yeah, thanks, Chair. I've got two questions as well. Sorry. I see from next steps that there are buzzwords here: inclusion, resident empowerment at the heart of neighbourhood services. And I'm just wondering, I mean, obviously you can't give very detailed reply, but how that might happen, particularly with regard to councillors, because I don't think councillors are very involved in this, and I certainly know for myself I'd like to be more involved, but how do you intend to do that? Because we can be quite key factors in bringing about resident empowerment. And I've just got a very specific question about service. What are the plans for Alzheimer's, where, unlike with cancer, for example, families and the care system have to take the burden? Thanks very much.
Have you got those? So why is this model different? KPIs, neighbourhood, councillor's role, Alzheimer's are sort of the four points.
Yeah, I mean, certainly in terms of how the model is different. So I do see this as building on what we already have established in City and Hackney. So it's an incremental change based on what's coming out from national guidance. Now, nationally, they've caught on to the fact that neighbourhoods are a good thing to do. So for us, actually, it's about building and actually making sure that we become stronger as a group of partners across the health and social care sector and the voluntary sector to make sure that we deliver care in the right kind of a way for our residents. So I don't think it will be a radical shift for us as compared to some areas that don't have neighbourhoods. But it's about making sure that we, do take into view national priorities in terms of success and the indicators that we'll use. I think one of the advantages about having this database and data, population health data to our disposal will mean that we can track some of these changes, both in terms of kind of in the short term and also in the long term around some of the projects that we do around proactive care. We've also, for example, done an evaluation on proactive care and how much it's benefited our residents, both in terms of the satisfaction level, but also added to the health economy by reducing, for example, emergency admission. So I think there'll be a variety of indicators used based on all the different types of projects that we have going on and will continue going on. And of course, encompassing that should be how staff feel about things as well. So what staff satisfaction like about working in a neighbourhood way of working, because we have to take our staff with us when we have this kind of way of, not radically different, but a different way of working within City and Hackney. In terms of the other question, so the inclusion and using residents in a meaningful way so that we're not tokenistically engaging with our residents. I think that's a really important point, and it's something that I think we've developed, particularly in the north around our childhood inns, going back to that example, quite well. We've got a community engagement manager, Selena, who works really closely with interlink and resident groups to try and make sure that actually the kind of engagement that we do with our residents is deeper than just taking ideas to them and saying, actually, this is the finished product, what do you think of it? It's actually them telling us, what do you think will work? Actually, a clinic at this site on this particular day, avoiding this holiday, using this kind of marketing will help. Sorry, the lights have just gone off. I think it's time to go home. Will work for this community, and therefore that's been the policy within our neighbourhood, and also will be something that will scale up across City and Hackney. And the last point about Alzheimer's, so we do have specific dementia navigators that work with both those people suffering or living with dementia and their families, and that service is been happening in City and Hackney for the past few years, and it works really well because I know when one of my patients who has dementia is deteriorating, I will get an assessment from that navigator that's embedded within the community and checks in with the family. And I think that has led to a more holistic service in City and Hackney.
I mean, Councillor Rathbone's pushing on the role of councillors. Do you see a role for councillors in the neighbourhood model? I suppose one area where I could sort of see some value add might be in signposting to different groups that are hard to reach or infrequently contacted, and possibly councillors' knowledge within that. So I suppose, is there greater scope for utilising that?
Yeah, absolutely. And actually, we do have Councillor Sam Palace that he came to our neighbourhood event back in the summer. He's been to some of our patient participation groups at Spring Hill. So actually, we're quite lucky to have that engagement from our local councillors. And actually, it has helped us unlock some of our barriers. And I think that is something that we should and we could strengthen for all the reasons that you've mentioned, Chair. Thank you.
Thanks, Dr. Grant. Right, very good. Councillor before hasn't asked a question on this item. Then I'm going to go to Councillor Kennedy. Then I'm probably going to wrap it up. Kirsten, is that a legacy hand or is that a fresh point?
It was a quick point around what we achieve in neighbourhoods, and it was about the outcomes thing. When we go back to what we are trying to achieve with neighbourhoods, it is about providing care closer to home, which is better for our patients, it's better for our health economy. It's about making sure that we are moving towards prevention rather than just treating things. So this is about the preventative agenda and managing those health inequalities. So we think about those are the measures that we're really looking about. And I just want us to remind ourselves that's what neighbourhoods is all about. Care close to home, prevention, health inequalities. Thank you.
Thanks, Kirsten. Councillor before.
Thank you, Chair. It says resident engagement has been deepened, but further inclusion and empowerment are needed. How is that going to be take on board in terms of engaging with people? English is their second language and that kind of things.
Just before I go back to Dr. Khan for the final time for that, Councillor Kennedy.
Yes, very quickly to say, as Councillor Patrick said and Councillor Turbot-Deloff, they've both been attended neighbourhood forums, found them amazingly useful, seen all the different organisations that turn up on what residents' primary concerns are. So actually Councillor Walker and I are going to do an email around again, reminding everyone how to work out exactly which forums, because many of us, our wards that we represent fall into 1, 2, and in a couple of cases 3 different neighbourhood forums. So we'll send around the maps again and remind people, but do get involved.
And very lastly, Dr. Just Councillor before's points about the engagement aspect, and you gave the example of those with English as a second language, and how you plan to reach out. If you could just answer that, and then I'll wrap this item up.
I mean, I think the key focus will be using our key partners that are embedded within the community to help with unlock some of that. So, I mean, I can use an example in Springfield Park that we have, which is the Spanish-speaking group, where Together Better have set up a group for specifically that community, of which there is a rising number that come and register with us from kind of Seven Sisters and North and South Tottenham into kind of the north of Hackney. And so there was found to be a rising need there with that particular community. So we have our social prescriber that leads a Spanish-speaking group. We're now going to set up a health check event where one of our nurses who speaks Spanish is going to do some health education and also provide a basic health check. So it is about addressing or looking at the need. What is the data showing us? That was addressing a specific need for a particular community. I've mentioned the Orthodox Jewish community and working and having close links with organisations such as Interlink and having a community engagement manager. I think that's the principle that we will continue to work with diverse communities, with our diverse communities across City and Hackney. And so, you know, I think that's something that we are committed to improving and continuing to make sure that we engage in an equitable way so that everyone has a chance to contribute to this agenda, and so that our interventions are tailored to our local footprint. I think that's essential.
Dr. I'm going to thank you very much. I mean, your passion for this area is evident, and we're lucky to have you in post. So thank you very much for your time in answering our questions. I've got some thumbs up here in the chamber as well, supporting that comment. It's exciting to see the emphasis being placed on neighbourhoods, and going back to the earlier item with Charlotte, it's clear that increasingly this is where it's heading for this phase of the NHS's sort of existence, in terms of emphasis on the neighbourhood model. So as that takes shape, it would be great to hear in due course what further work is being done, and where it's taking us. And I think we know from previous conversations, estates can be a block there. And so if funding is becoming available, what can be done in that regard as well. So I think in due course, it may be, whether it be in a year's time or so, or a little after, it'd be useful to have an update on this as to where we are. But with that, and thanking all of you for your work on the neighbourhood and place-based system in Hackney, both Steph, Kirsten, and you, Dr. Khan. Thank you very much, and I'm going to bring that item to a close. I'm now going to move on to the final substantive item on the agenda, which is the NHS Federated Data Platform. This is a new data sharing programme or process that's been instigated, as I understand it, by NHS England, and they have, as I understand it, signed a significant contract to try and create better sharing of data across the system. We've got about 35 to 40 minutes for this item, and as I understand it, I'm going to have Niall Canavan, who's the Chief Information Officer for both NHS North East London Health and Care Partnership, and also the IT Director at the Homerton. I'm grateful, Niall. I think you've provided a very helpful presentation, which I think you're going to speak to. And then I've also got Tom, Nettle, Stephanie, and Kirsten down. But as I understand it, that might just be more to come in at particular points rather than do fully fledged presentations. Tom, tell me if I'm wrong in a minute. And then in the chamber, we're welcome to have Duncan McCann from the Good Law Project, who's an expert on data and technology law. I'm going to let Tom come in a minute, but subject to better views, my plan would be for Niall Canavan or Tom to maybe do a 5 to 6 minute presentation on the platform, open it up for a few questions, just a few, then go to Duncan, then open it up to a few more, just to try and keep it as a bit more of a debate rather than just being spoken to by people. Tom, do you want to come in?
Yeah, just very briefly for clarity, thanks, Ben. Niall will cover off the ICB NHS England position, and I'll briefly cover off where we are at Homerton on behalf of Homerton.
Perfect. Okay, fine. Thank you. So, Niall, do you want to kick off, and I'll quickly come to Tom?
Thank you, Ben. I'll be quite quick. I've got your message. So I want to just cover 3 areas. What problems were NHS England thinking they were fixing with this NHS Federated Data Platform? What a federated data platform actually is, and then finally, what IG arrangements are in place to make sure that it meets with data protection legislation and the common law duty of confidentiality. So, very basically, every single trust, we alluded to this earlier, has their own informatics team, their own systems. If you try and create, say, a waiting list report, how many people's been waiting over 18 weeks? Homerton might run the data for that on a Tuesday, Barts might do that on a Thursday. The ICB happens to need it on the Friday because that's the first of the month when the report's due. You think you're comparing apples with apples? You're probably not. When you add in sort of dashboards, analytics, advanced AI analytics, you're definitely no longer comparing apples with apples. You're doing something quite different. So the whole idea of a federated data platform is that basically NHS England went out and said, we're going to have a common data infrastructure. There will be a national instance that NHS England use, and then each individual ICB or trust will have a common instance, their instance, which will be exactly the same. So if you put a waiting list report on that, everyone will get the same data because we're using the same data definitions, we're using the same extract and load timetables. So we will get consistent reports across, and you'll be able to look at waiting list positions. The other idea is that on top of that, you can then add what they call platforms, which we call dashboards or analytic tools. So they're starting to develop things like waiting list initiative applications where you can look at the people who might breach within the next few weeks. That allows you to then bring those operations forward earlier, and you can minimize the number of breaches. Again, common tools on common data sets that all organizations use, and it's transparent. So the ICB can see what's going on and NHS England can see what's going on. So that's the idea, and that's what a federated data platform is. To make sure what NHS England did was contract with a consortium of companies. One of the companies they contracted with is Palantir, that's for the national and the local data platforms. And they also contracted with a separate company called IQVIA, which provide what they call PET, which is privacy enhancing technology. And basically what they've done is separated the processing of the data from the security and the access to the data. So the people who process the data don't control who uses it and who's access. That's a separate organisation. What NHS England have then done is put contracts in place with both those organisations and NHS England. On top of that then, because basically NHS England is a data controller and IQVIA and Palantir are both processors. If we as an ICB or we as a trust want to use a local instance, we also then act as a joint controller because we're a controller of our data, which we will put into our instance. And what we will then do is a data process agreement shared with the IQVIA PET contractor, and we will also sign a data processing agreement with the Palantir data processing contractor. And that provides the whole IG framework, which meets the sort of data protection legislation requirements and the Common Law Confidentiality Act. I'll stop there. It's quite a lot of information in a very short piece of time, Ben, and maybe hand over to Tom at Homerton's position.
Tom, thanks.
Thanks, Niall. Thanks, Ben. Just really quickly, so from a Homerton healthcare perspective, a few things that it's perhaps worth sharing and being clear about. So while implementation is not currently mandated in relation to using the FDP, all trusts and ICBs are being asked to provide plans as to how they'll maximise the benefits of the NHS FDP offer for patients within the next 2 years. It's probably worth noting at this point that the FDP solutions themselves are free to NHS trusts, while other equivalent solutions, certainly if they weren't created in-house, would have a cost if they were provided by another organisation. At Homerton, we are currently going through an active process of reviewing how we might make use of the FDP. They offer various solutions and we're looking at those. We're still considering whether a solution would offer us a benefit at the trust. And that consideration or set of considerations is ongoing. As part of this, we are speaking and seeking detailed feedback, not just from the central team in NHS England, but from a large number of trusts who are already using it. It is also then worth being transparent about a couple of things. The first is we are in effect participating in an FDP system. We're providing data on London ambulance A&E admissions. So that's not patient related data, but specific performance data via the NHS FDP to the LAS, London Ambulance Service, My Clinical Feedback app, which provides London Ambulance Service clinicians with feedback on clinical conveyance decisions covered by appropriate DPIAs and data sharing and processing agreements. The final thing to say is, and this hasn't yet happened, but it may happen, should NHS England or NHS London, who are the London element, regional element of NHS England, choose to use the FDP systems or solutions to monitor and manage performance, then it's worth being clear Homerton will be required to utilise FDP as part of those processes. Thank you.
Thanks, Tom. So just before I open up to members, so it sounds like if it's not being mandated at the moment, I mean, if the whole, one of the driving forces behind it is to for transparency and comparisons, and presumably there's some cost saving there as well in terms of trying to pull data from different sources as opposed to be done automatically. It could be a matter of time before the direction of travel is towards it being mandated by the looks of it or not. Or is that a fair description? No.
From a Homerton perspective, we genuinely don't know, Ben. I think, you know, but we are being asked to ensure that we provide updates. The second thing I guess to add, which we didn't say, is there are intended to be opportunities in terms of economies of scale, but also the opportunity to perhaps far more cheaply than we might otherwise be able to look at advances in digital technology that might allow us to better manage demand of patients or patients' access to care through the use of artificial intelligence at some point in the future. That's some way off as I understand it, but it's worth being clear those opportunities are spoken about. Niall, you may want to add.
Yeah, you're exactly right, Tom. It's that the idea is if you have that standard platform, you can take advantage of new technology quickly and for everybody, because you put it in one instance and everyone can do the same thing with the same data sets. That's the ambition, I think.
And just before I bring Councillor Lucas in, back to Councillor Patrick's earlier point about the possible benefit of adult social care information being accessible, say, at neighbourhoods, or what with the early discussion about neighbourhoods being able to pull data trends and things like that across their area. At the moment, would the platform, or could the platform, include adult social care data, or is that not currently in the envelope?
At the moment, it's restricted to NHS organisations, but the framework would allow. And what would happen then, social care as a data controller would have to make the decision that as a data controller, they wanted to put their data into the platform and make sure that the appropriate data processing agreements were in place with the providers. So the structure is there to enable more. At the moment, they're just concentrating on NHS trusts and ICB. So they haven't approached primary care yet, even, for example. They're just concentrating on acute trust primarily and looking at waiting list initiatives and ICBs as well.
Thank you. And Councillor Lucas?
Yeah, thank you, Chair. My quick questions for Tom, really, just from a Homerton perspective. You've said obviously it's not mandated at the moment, but you're sort of assessing use cases and you know, looking through the viability of it, etc. Can you give the committee a sense of the timelines of that, when you're expected to report back, and any recommendations? And is that kind of months, weeks? When are we going to expect a decision on that as the platform's being sort of advanced? Thanks.
Yeah, that's a very good question. We haven't actually specifically set the timeline, so I'm a bit hesitant to set it in this meeting for the first time, as you might imagine. However, there are a couple of organisations we do still need to speak to. We're confident we'll get a really clear understanding, confidential, obviously, understanding from them about how effective they found the FTP solutions. So those haven't taken place, and then we'll need to take it through our organisation. It will be months, though, as opposed to anything longer than that. So I'm sure we'd be happy to update then. It is worth saying, though, we may make one decision in a month, 2 months, 3 months' time, and then revise that again, because the offering of the solutions and the extent to which they're effective is clearly developing on a regular basis, and that's something we need to keep under review. Equally, as we look at what we might need to want to do and change in terms of how we manage data in our digital solutions, we'll need to return to something like the FTP alongside other options.
Thanks, Tom. I saw Councillor Adams and Councillor Turber-Delov, and then I'm going to, I've seen Councillor, I think what I'm going to do is I'll give Councillor Adams, Councillor Turber-Delov, I'm going to go to Duncan to bring you in, and then I'll go to Councillor Adebayo after Duncan's done his presentation. So, Councillor Adams.
Thank you, Chair. My question is, what specific problems within the NHS data management in the federated platform intended to solve? That's my first one. And then, how does the FDP differ from the previous data sharing system using in the NHS? Sorry.
Thank you. And I'll take Councillor Turber-Delov now, just for the interest of time.
Thank you. Thank you. I know that we'll probably ask this question in my hat as governors when I'm in governor meeting, but here I'm with my hat as a scrutiny member. I guess my point is around the ethical side of things with this platform, because it is known to have really serious ethical concerns, because this platform really has profited from surveillance, policing, and immigration enforcement, including ICE in the USA and against the Palestinian communities. Now, my question is, are these ethical issues being fully considered when assessing whether adoption of the NHS federated data platform perhaps could create additional concerns and affliction to residents who will know that their data is being managed by such platform with ethical concerns. Thank you.
Can I suggest that Niall takes the first two questions and I take the third one?
We've got feedback from the audience. So the do you want to take those one or two of those there, and then I'll go to Niall as appropriate?
Yeah, so let me take the, sorry, that was what I was, apologies, Ben, for the feedback. If Niall was to take the first two questions made by the first councillor, I'll take the second one, I'll take that second one now. We've been clear about what we're considering, and we obviously need to listen to and take into account the concerns that are being raised here and by our representatives from the public who attended our Council of Governors, but equally we look to the assurances and the evidence that NHS England provide, and I think Niall set those out both in advance in writing and in detail verbally, and we do have to make sure that we take those incredibly seriously. What I can say is that as we understand the concerns of colleagues here and elsewhere better, we're considering the best way to balance those with the other considerations around what opportunities the FTP may offer if we were to choose to use one of the solutions.
Niall, I want to come to Duncan's going to talk about some of the concerns more in a minute, but Niall, just in terms of Councillor Adams' question in terms of how does it differ from the current offering?
Yeah, so the current offering, there's two bits. We do routinely share clinical information with our health information exchanges or our shared care records. That's sharing clinical information, and one of the speakers referred earlier about how they're at the hospital, you're able to look at GP data and vice versa. That's a direct point of care. What FTP is trying to solve is that more your data warehouse and your routine statutory reporting, your analytics, your population health, and all that at the moment is done differently by every single different ICB or trust on internal resources, and they all come up with slightly different internal answers. So what the proposal for NHS England is, that is a standard federated platform that everyone can run the same dashboards and get the same solutions. That's the kind of main difference, I think.
Thank you. I'm now going to turn to Duncan, and Duncan's helpfully provided a presentation which is in everyone's packs. Duncan, again, if you could maybe just do 5 or 6 minutes presentation, and then I'll open it up to questions.
There we go. Okay, thank you very much for having me. It's a real pleasure to be here. As a Hackney resident for 20 years, it's really nice to be sitting here rather than up there in the gallery. Yeah, I'll just try and take 5 minutes to kind of go over some of the reasons why I think, although it's clear that the NHS needs to improve its data practices, I think there are just absolutely massive questions about whether Palantir is the right company that an organisation like the NHS should be contracting with, and where public money should be going to. And I'll cover it quickly along 3 aspects. I think there's the type of company it is and the work that it's been doing around the world, which the previous councillor already mentioned. There are real issues around trust, data rights and security, which I'll try and go into very briefly. And then finally, there's a real question about whether it actually performs technically and does actually deliver benefits to the NHS, and also whether it generates strategic risks for the NHS going forward. So I'll try and cover all of that in 5 minutes. So I think first of all, it's really important to remember that companies, and I've spent like over a decade trying to hold companies to account, as well as previously a decade in compliance. Companies actually do have personalities, and they do vary in how they comply. And if you just look at the kind of statements that Peter Thiel and Alex Karp, the CEO and one of the founders of Palantir, make, you can see it's a company whose values do not align with the NHS. Peter Thiel on record as saying that the NHS is making people sick, that we're suffering from Stockholm syndrome because we love it so much. Alex Karp unable to say whether humanity should survive the other week. It really is a company that doesn't fit with the ethos, ethics and values of the NHS, and I would argue even with the UK people. You've then got to look at what's it been doing in the 10 years or so that it's been practicing. What other contracts has it done? What other work has it been doing? And unfortunately, it's a litany of abusing minorities, helping authoritarian regimes, be that across the US, be that developing predictive policing algorithms which try and predict where crime is going to be, which have been shown to be hugely biased, whether it's collaboration with US Customs and Immigration and ICE and the current really shocking scenes that you're seeing from the US of people being rounded up in mass deportations, absolutely facilitated by Palantir. And that would already be enough, but they were also complicit in, I think, Israel's genocide that's going on at the moment. I think, not only have they been providing technology for the Israeli government for a long time, but they have actually increased their cooperation and increased the work that they've been doing. And again, that's just not enough. They've also been working hard across a number of other jurisdictions to build in heavily surveillance programs, again, that have a reputation of targeting minorities and being very oppressive. So I think there's a real problem with whether this company is a company that should be giving 330 million of UK taxpayers' money. That is not the end of it. About $1 billion is forecast to be given. And also, once they're in with the FDP, who's going to deliver the single patient record? Again, it's much more a lock-in. But it's not just their company behavior elsewhere that's a problem. I think there's also a real problem for how it might work for the NHS. Patient trust is absolutely critical. And indeed, we share our data with the NHS, and we have rights, and the NHS has obligations for that. Indeed, the previous two massive IT projects, Care.Data and GP-DPR, both resulted in multi-year initiatives that both failed because ultimately they just, amongst many other reasons, one of the many reasons, they just didn't bring people along with them. And each of them, in fact, resulted in possibly, about 1 million people opting out of the data set for valid reasons. Now, at Good Law Project, we've campaigned against many adversaries, long litany, but I don't think there is one that unites people as much as Palantir. And I think there is a real risk that the NHS, one of our crown jewels, which is the NHS's data set, because of the unique way that we do our health service, we have this very unique health data set. And polling from other organizations shows that as many as almost 50% of people may opt out of sharing their data if a company like Palantir is given access to it. This hugely devalues the data. It means there is lots of insight that we could get from it that we will never learn from it because people are not willing to have their data shared with an organization like this. And I think finally, if I quickly just follow on to the kind of the quality concerns and the strategic risks, I think it's great to hear that Homerton is still evaluating whether it can provide a benefit. I hope as well as looking at the trusts who are claiming a benefit at the moment, they will also look at those who have declined the FDP, who have made clear that the systems that they have in place are already better than what the FDP is delivering. And so I just hope that there'll be a balanced look at that. I think as well as whether the technology is up to scratch, there's also then this real concern about, well, is this the one-way street that the NHS is going down? Once we've gone down and we've integrated it all and we've spent not only the 330 million, but they've got phase 2 and phase 3, and they're deeply embedded in the contract, how, if something were to go wrong, as it has with other contracts, I think it's New York tried to extricate themselves, and they had to, you have to build the system back up from scratch as soon as you don't like it. So given the kind of corporation this is, given the kind of other projects they're involved in, given the kind of risks involved, given the lack of trust from patients out there, I think there is a real risk that this provides a lock-in to a service that ultimately is not fit for purpose and is not going to deliver what people hope. And I think I'll just end as saying that as well as all of these other concerns, there's a huge concern amongst NHS workers. The BMA has officially come out saying that they don't recommend the FDP. We are in touch with workers in many trusts across all levels of the NHS who want to resist the rollout. Huge concerns. So yes, I think it's a litany of concerns, notwithstanding the fact that we do need to address the problem of data in the NHS and how to maximize it. Just massive questions about how Palantir could be the suitable and the right candidate for it.
I've got Councillor Adebayo. Duncan, in terms of the trust point and significant people opting out, I could see how that could cause a challenge. Lots of trusts, some trusts, I don't know how many have already adopted it. What do you have any data or information about what the opt-out is on those that have, in percentage terms or other terms, have actually opted out of it, of those trusts that have adopted it?
I don't think I think the awareness of which trusts have adopted it is very low. So I think when you go to most areas, people are not aware of whether, X trust or Y trust. So I think it just matters about whether it gets out. And then once the message gets out, that's when people engage. The challenge is the opt-out doesn't really deliver what people want. The national data opt-out, which the NHS have put in place, is not the same as the objection as in law, and indeed this is something that the Good Law Project has been engaged in a long-standing discussion, let's say, with NHS England about how that works. And indeed also what your rights to opt out are. You don't have a right to opt out of the use for your primary care. You only have for secondary uses like planning and things like that. And so there's also a big question from our side about which activities are Palantir doing that are primary and secondary, and that's partly why we need this transparency. And if there's another feature of all of Palantir's engagement, it is an absolute lack of transparency, secrecy, trying to keep things behind closed doors. And indeed, Good Law Project had to fight very hard to get the contract that the NHS England had with Palantir, which originally was about 500 fully redacted pages, which Good Law Project had to take the government to court for to get kind of released. And so without the transparency, we can't know any of this. And that, again, breeds this mistrust in the system.
Councillor Adebayo.
Oh, thank you. My concern is about the migrants and the asylum seekers. The community that may feel that their data could be used inappropriately by sharing with Home Office. So I just want to know if there is any way they can be given a consent of opting out from their data being shared. Do they have that privilege of opting out?
Niall, do you know the answer to that question in terms of?
Okay. Do you want me to?
I'm sorry.
Okay, rephrase it. There are communities, right, like the migrants and the asylum seekers that may feel that their data could be used by the Home Office in surveillance. Do they have the option of opting out from their data being shared?
Niall, do you know the answer to that in terms of whether there's an opt-out for data being shared?
I think that needs to be answered to NHS England. They're the contract holders, and they publish their privacy notice on their website, which is all about what can and can't be done in FDP, and they make their statements quite clear. But I wouldn't like to represent NHS England's position in case I got it slightly wrong, if you see what I mean.
I understand in terms of sort of your role there within that. Duncan, have you got anything to add on?
Yeah, just so that, I think at the moment there's no plan to share that data between those agencies. But I think the real worry is that there's going to be function creep, especially once we've spent £1 billion on it, because we're going to need to extract all the value we can. And somebody will come along and say, oh, we could do this really clever thing where we could share it with the Home Office, and then we'll smooth out some process. So absolutely, I think it's a real fear. And my understanding of data law is that no, people would not be able to opt out of that bit of data sharing because the government would claim the legal basis of performing a public duty, because for them it would be about complying with the law, and so it would be a public duty. And so as individuals, we don't have the right to opt out of that kind of work, in the same way that I can't stop the police processing my data because they just have a right to do so. That data sharing could also be covered under that arrangement and thus take it away from people's agency.
Councillor Adams?
Thank you, Chair. Thank you, Chair. So what independent oversight mechanisms are in place to verify data security and ethical compliance? And my second question, I always try to ask two questions. My second question is similar to what Councillor Adebayo is trying to ask, which is, how is patient consent managed, particularly given that many patients may not be aware their data is being part of the system?
Niall, are you able to answer those?
Again, I think, I don't want to cop out, but the NHS England is their contract and they run the federated data platform. And they have published their information governance framework, for example. They've published their FTP privacy notices. A lot of those information requests are kind of detailed on those websites, and I would direct people to have a look at those and see what NHS England says on this, rather than rely on my interpretation of what I think NHS England says.
That's I understand that now. Just in terms of then opt-out, what's your understanding of that in terms of whether, so let's just be hypothetical here, or Tom, if the Homerton did sign up to it, are you aware of whether, say, patients or residents could inform the Homerton that they wanted to opt out of their data being added to the platform? Are you aware of how that sort of system works?
I'd said the normal opt-out process is if it's a direct care application, so I'm not talking FTP here, so we're just talking normal data sharing. If we share data for direct care, then patients can't opt out of that. So in that example earlier, for example, where if someone comes into A&E at the Homerton, we can see their GP record because we're treating that person for whatever's affecting that person. That's direct care. If there is a direct care use of FTP solutions, then opt-out would not apply to a direct care use. Opt-out usually applies to secondary care uses like research, innovation, all that kind of stuff.
Thank you. And Councillor Rappin, do you have is that a legacy hand or is that a question? No, thank you. Over to you.
Okay, thank you. First of all, just to say to Duncan, thank you very much for this report. It's absolutely excellent and a real eye-opener, actually, as to what is actually going on. You can't hear me? Terribly sorry about that. I need a doctor because I've got a cold.
Just speak closer into the mic.
Yeah. Can you hear me now? Yeah. So thank you, Duncan. I've got a kind of two questions. One is that I'm very concerned about on page 39, if I can say this word correctly, pseudonymization. Did I get it right? Yeah. So I wondered what Duncan and both Niall thought about that, where, you know, apparently in Australia, patients were identified from data set officially released by the government. That's a considerable concern. And kind of linked up with that is, I just wondered, and I don't know whether it's Duncan's done investigation, but I mean, Niall should surely know a bit about it, is who is Palantir, whatever they want to call themselves? What is this company? Who owns it? Who are the directors? I mean, you know, this is a company that's responsible for, you know, what you're saying is up to £1 billion worth of data, of work. So, I mean, do we know anything about them?
If I go to Duncan to answer in terms of the Australian example and any further information in terms of Palantir, and then I've got Nick who wants to ask a question, and then I think we are going to be out. Oh, Councillor Tozilov, out of time. So quickly, Duncan, if I could ask you to just respond to Councillor Rathbone's points, and I want to get the others in before we close.
Yeah, I mean, the pseudonymization bit, so it all depends a bit on, and I think some of the other speakers spoke about, so Incuvia is the company that's been hired, that's been part of the contract that will pseudonymize the data. What we need to do is really, understand the process there, because pseudonymization isn't just, there's only not one way of doing it. There are literally hundreds of ways of doing it. It's a range of things between, you know, just putting a sticker over our name and, you know, that would be pseudonymizing, to, you know, adding noise data so that it's hard to see what's real and what's not. There are lots of very sophisticated ways of doing it so that you could get to a place where it's relatively secure. The problem with health data is that it is so individually identifying by its very nature, and therefore poses a really serious risk of re-identification. The other thing to remember is that although we all do our best, those who manage sensitive data sets, to keep those things secure, sadly, we do see data breaches happen regularly. And so we must be mindful that there is a chance, and a not insignificant chance, that some of this will get out, and that technology, especially as it advances, will make re-identifying data that's been pseudonymized easier and easier. And so there is a real concern about that process. Again, how well it's being done, how easily it can be reversed, and exactly what security components are being put in place to secure our data. Or some of that is slightly clear, and some of it's murky, and some of it's impossible to see, at least from our side of the game. It's probably, these guys might have some idea, but yes, very hard to see from where we are.
We've got about a minute or so left. So Councillor Turton-Love, then I will bring Nick in. Councillor Turton-Love.
Thank you, Chair. This question actually might be for Councillor Kennedy, but I appreciate you might not have the answer, or maybe we can bring it back as well, but also to the people that are speaking on Palantir. I'm just thinking in terms of, my colleagues have talked about, and I'm really glad to hear because I know they mean it, in terms of, the most vulnerable residents. It won't surprise you that I will talk to you about migrants, and I work predominantly with a lot of people that are undocumented, so the concern already is there. So thanks, Duncan, for also sharing what you shared. I'm just also mindful that we are in a process of becoming a borough of sanctuary. How does this sit with a platform like this, managing the data of residents in Hackney, especially those who are already scared of accessing healthcare because of perhaps immigration status? And how does that sit in our process of becoming a borough sanctuary? And I know that we mean a lot, we really care about our migrant community, but I just feel that maybe there is a real conflict there, and I would like us to take it really seriously. And I know that, I see Councillor Kenny already taking notes. We might not have the answer for that, but I really would like that to be a consideration. We are becoming a borough sanctuary. We really care about migrants, undocumented, non-recourse to public fund asylum seekers, and refugees. So how does this very, in my view, unethical platform sit with that? Thank you.
Okay, good. So I've got, quickly, we're out of time. So Councillor Patrick, then Nick Mann, then I'll draw it to a close.
Thank you. I think it's page 50. I was trying to find it. I'm particularly worried about how the company platform is building this data. I suppose this is really to the NHS, but the fact is that when the contract comes to an end, it's suggested that it's going to be really difficult to get out of the contract because they will build the database in such a way that it won't be transferable to anybody else, and we'll have to keep, and the cost of getting a new company in will mean they will have to build the data from scratch rather than it being transferred. This is our data as individuals. It's the NHS's data, which is the British government's data, but it's not the company's data. And it should, it should be. The contract's been signed, but the database should be done in such a way that it can be transferred if we don't want to take the contract away. But that's looking like, from what I've read, it looks like that's going to be very difficult, or it may be difficult. Perhaps somebody can comment on that.
Councillor Moore hasn't asked a question on this two-sentence question, if I can hold it to this.
Thank you very much. I always become the last one. Thanks for the opportunity. Anyway, Neil, don't you see the risk of vendor lock-in as a potential challenge for your role in the future, and also to be seen more like Big Brother having the opportunity to control the whole system in the future?
And Nick, finally.
Hello. I'm Nick Mann. I'm an ex-GP now. I'm also a public governor at the council, the governor of Council of Governors at Homerton and a member of Keep Power NHS Public. There are so many warning signs about Palantir, and some of these have been iterated. They are indeed building monopoly, which will be largely irreversible. They're talking about kind of building in the DWP, the Home Office social services, into their framework as well over time. And obviously these are very, very early days. So we're looking at very soft services like the London Ambulance Service admission. Nobody's going to have a problem with my clinical feedback, but there is a lot of interactive data coming. There are real concerns about the transparency. The business use cases has been refused. As Duncan said, the contracts were heavily redacted and only opened up under law. The previous use cases really speak for themselves, with care.data, which I was involved with, and the GPDPR, both of which failed because they were untrustworthy, untrusted, and in fact they were lying about what they were offering. My understanding of the Data Use and Access Act is that with planning and research there will be no opt-out. As far as I understand it, that is the situation, but I haven't looked at it closely for a while, so I'm not sure that that is correct, but I'd urge you to look at it. I mean, in terms of the ethical consideration,
we're running out of time, so just ask you to bring it to a close.
Okay, look at the Guardian and Palantir's. He's actually saying that, talking about the Antichrist, given a series of 4 lectures, and sort of candidates for the Antichrist would be Bill Gates and Greta Thunberg. What I really wanted to say to you was, it is a short comment from the Health Service Journal, which is actually about how the operational FDP is functioning at the moment, and the fact that Cerner, which is another American, it's the opposite, it's Larry Ellison's Oracle company, has really been sold, we've been sold a pup by Cerner. It's really poorly functioning. And what he says about the FDP, he talks about oh, excuse me.
I have to bring you to a close because we're over time here, and so can you make it the last couple of sentences, please?
Yeah, basically the operational is the operation of the FDP as it exists at the moment. Trusts using it are finding that it's not integrating. It doesn't work in a lot of cases. It's often no better than what's being offered at the moment. And many trusts, many of the people on the ground who are using it are saying they've been sold a pup. And the people who are in the know it, and the very few people are in the know, and those who aren't are likely to find out that they have been sold a pup. So my question would be, what can Homerton do, and what can Homerton do nationally to ensure, and I mean taking active additional steps to ensure, that the FDP is not another missold pup upon the NHS and on patients?
Thanks, Liz. So very quickly, I'm just going to do the final round of questions and answers. So Councillor Kennedy, quickly on Borough of Sanctuary. Can I then ask Duncan just to come back on Councillor Patrick's point about the end of the contracts and where the then data goes, and then I'll just come back to Tom briefly on the Homerton, and then we'll wrap it to a close. So Councillor Kennedy.
Yes, Councillor Turbot-Deloff, share your concern. I'm going to raise it with Dr. Husbands, and actually Councillor Williams has asked us all as Cabinet leads to talk to our lead officers with reference to Borough of Sanctuary and the ongoing consultation.
And Duncan?
And yeah, just really with regard to the data and kind of the end of the contract, it wouldn't be so much that they would take charge of our data, and indeed they're contractually bound to not take our data. It's that the processes and systems and architecture that had been built over the 5 or 10 years of the program, that would all go away. And so our data's useless without processes and systems and architecture and things to do things with. And so we would have to rebuild all of the hard stuff from scratch or go to a new vendor, you know, but yeah, it really wouldn't be easy to row back once we're heavily invested.
And Tom, finally to you, please.
Thanks, and grateful for Nick setting out his concerns as clearly as he did. Just to reiterate, we're considering and reviewing the benefits of utilising the FDP. It's been extremely helpful to have people express their concerns both here and at the governors, and we'll update you once those considerations have come to a conclusion.
Thanks, Tom. I think you can clearly sense the significant strong feelings about it and concerns being raised. So obviously at the point when you have made the decision, I also hear your point about how you manage the data is a constantly evolving situation as technology evolves, etc. But at the point that you have got something to share, clearly, if you are able to do so in the interest of transparency, that would be appreciated. If you could just let us know, I think that would be in the public interest. So thank you everyone for coming to inform us and speak to us in terms of this item. I'm going to bring this item to a close. Members, can I ask you just to wrap up the meeting? Minutes of the previous meeting agreed, please.
Sorry, Chair.
Work programme is at the back of the
Chair,
agenda.
sorry.
I
Can we
haven't been
acknowledge
notified
the
of any other
residents that have stayed for till the very end almost just to hear this item and very peacefully and very comradely? Thank you.
Sorry, Councillor.
Just to acknowledge residents have stayed until quite late to hear this item, very important item for us. Just want to acknowledge the residents.
We had a long history on this committee of public engagement going back 14 years. So it's grateful to see so many residents. Thank you.
Thank you. Report from the American Friends Service Committee analysing the activities and products of technology. I think you might be persuaded that the ethical cost of a contract with this organisation is too high. Thank you.
Thank you. With that, I'll close the meeting. Thank you, everyone.